Thank you, Pallavi ma'am. Yes, I am the host now and I've shared my screen also. So I guess there are 11 participants. We'll just wait for 2 minutes more and see if others are joining in and we'll begin with the class.
Good morning, madam.
Yes, good morning, sir.
Good morning, everyone.
Good morning, Dr. Rabia. We are missing Munjal sir for the mock test these days.
No, I'm here. I'm learning.
Sir, we really miss you.
No, we'll back to the work. I mean, I'm on work now, but we'll be in coaching next Sunday, sure.
Yes,
Inshallah.
yes, sir.
Right now, I'm learning from Dr.Akankssha and Dr.Ramya. So, I mean, how to.
Sir is into student mode these days.
Yes, yes,
That
yes,
these
yes.
are these are very excellent teachers.
Good morning, sir.
I
Dr.
really
Ramya.
appreciate them.
Good morning, madam. How are you?
Yeah, doing well, sir.
Great, wonderful. Love to see you soon.
Yeah, you are in Dubai, right? Meet you, sir.
Yeah, I just reached last night. So, settling. So we'll let me know when you're free. We'll call you
Yeah, sir.
after class, no problem.
Okay, sir, no problem.
Yeah. Start,
Okay,
ma'am, if
students.
possible.
Yes, yes. Okay, students. So, welcome back to the mock test as our every Sunday pattern. And we'll soon begin with the classes. So, we already have Dr. Munjal sir with us, whom everyone knows. This is myself, Dr. Akanksha. This is a brief introduction about me. I've been into coaching for FMG, NEET PG, as well as MBBS UG students. Been into the author for 2 and 3 publications for the books. NEET PG book is still in progress. And also as an international MCI faculty for the foreign medical graduates, Kazakhstan and Russia. So, further not wasting time, let us get back to our studies. Okay, the first session will be conducted by me, and the second session will be conducted by our expert, Dr. Ramya. That is between 2 o'clock to 3 o'clock. Okay, Dr. Ibn Azar has raised the hand for you can post your queries in the chat box. Okay, so coming to the first question, see, today's session is going to be on pharmacological drug based associations and what will be the drug of choice. This will be the first session, and here you will be able to understand if there is a clinical scenario, what will be the ideal drug of choice and what will be the contraindications. So, there are a lot of one liners that you will be learning from this session. Please pay attention, and if needed, you can take screenshot of the few slides which are coming up. Okay, so the first question for today, a 52-year-old male, type 2 diabetes mellitus, plus microalbuminuria, and his BP is 156 by 94. His creatinine is normal. What will be the best drug to start? A. Amlodipine, B. Hydrochlorothiazide, C. Ramipril, and D. Metoprolol. Kindly post your answers. Okay, so majority of the students are saying that the answer should be C, that is Ramipril. Can anyone tell me why the answer should be C? Why Ramipril and what class of drug is Ramipril?
AC inhibitors, ma'am, angiotensin converting.
Okay, perfect, very good. And A. Amlodipine is what class of drug?
Calcium channel block.
Perfect. Dr. Shailja, if I'm not wrong.
Shahila. Shahila,
Shahila.
ma'am.
Okay, sorry.
Yes.
And metoprolol is beta blockers.
Beta blockers.
Hydrochlorothiazide is what class of diuretics?
Thiazide diuretics.
Okay, perfect. So, as we see here in this question, there is a 52-year-old male. He already has comorbidities of diabetes and has microalbuminuria. So, that means his urinary albumin creatinine ratio has to be more than or
More
equal
than.
to 30. Okay, and
Yes, ma'am.
also he is having hypertension. So, in such clinical scenario, the best drug to start with will be ramipril or the ACE inhibitors. What will be the initial dose that we are going to start of these drugs?
2.5.
Very good. So it is going to be either 2.5 OD or it is going to be 5 milligram OD. Okay.
Yes,
Now
ma'am.
let us see the explanation. Here, ramipril is the correct option because diabetic nephropathy protection is given by diabetes. As I already told you, that is the UACR ratio is if it is high or more than or equal to 30, your drug of choice should be ACE inhibitors. It reduces the intraglomerular pressure, reduces the proteinuria. Basically, it protects against the diabetic nephropathy. So, we want the long-term renal survival. That's the reason that we are going to choose ramipril as our correct option for this scenario. Why other drugs we cannot give? See, all are antihypertensives, but in this case, why did we choose ACE inhibitors? These are the 5 main reasons. First, it is going to correct the nephropathy, then reduces the intraglomerular pressure by reducing the pressure in the efferent arterioles, then reducing the proteinuria. Also, the long-term kidney survival or the renal survival benefits will be there. The golden line to remember here is diabetes plus albuminuria. Even if the BP is mildly raised, not that high or not grade 2 of hypertension, you can say, still you have to start with the ACE inhibitors. Now, CCBs, we are not going to start here. The reason being it is not renal protective. Then hydrochlorothiazide, it can only cause mechanical volume destruction. That is, it is going to only reduce the fluid overload. And the metoprolol, it is only going to control the rate. There is nothing related to the rate in this patient. There is no history of arrhythmia. There is no VTAC or anything like that. So therefore, not metoprolol, not hydrochlorothiazide, and not the calcium channel blockers, but ACE inhibitors will be the drug of choice. Now, as we know here, the ACE inhibitors which we prominently use are ramipril, enalapril, lisinopril, and perinidoprid. All these are having equal benefits, but these days most commonly used are going to be ramipril and enalapril. Okay, as we always know, what is the mechanism of action? ACE inhibitors, that is angiotensin converting enzyme, from angiotensin 2 to angiotensin 3, we are going to stop the angiotensin conversion. Because of this, what is happening? The efferent arterial pressure is going to be reduced, glomerular pressure is reduced, and the protein leakage is also reduced. Okay, so this is the basic about your ACE inhibitors. Now, coming to the second part of the slide, there are few scenarios which has only one answer. For example, if there is a patient with DM and proteinuria, just like us right now, the ACE inhibitors will be the first line of choice. But if the patient is not tolerable for the ACE inhibitors, we can start with ARBs. What are the ARBs? Drugs like telmisartan, olmesartan, losartan. Those are your angiotensin receptor blockers. Okay. Now coming to pregnancy. In pregnancy, if the patient has hypertension, what is the drug of choice? It is going to be labetalol. Bilateral renal arterial stenosis, the drug of choice, we have to avoid ACE inhibitors here. Why? Because as the ACE inhibitors, they act on the arterial constriction and they mainly act on the kidneys. But in renal artery stenosis, we cannot constrict it more. That's the reason that we are going to avoid ACE inhibitors. And if there is some side effects that is developed due to the ACE inhibitors, as we know, we are going to start with the ARBs, that is angiotensin receptor blockers. Now, before going ahead with the diabetes drugs, we have to learn what are the recent classification. This is just for your information. Sometimes in the question, they just mention DPP4 or they mention SGLT2, but you should exactly know what drugs come under what classification. So just take a look on the slide for 5 seconds, refresh your memory, and then we can go ahead. The GLP-1 analogs, these are the recent ones which are also popular among the weight loss ones. That is your Ozempic, Manjaro, all these fancy names. But leaving aside the weight loss part, weight loss is a side effect of those drugs. The main act on the sugar control. That is, even if the patient doesn't have diabetes, still we can give GLP considering the weight loss benefits. If it is SGLT2 inhibitors can also be given in the non-diabetic people if they are having cardiorenal risk or they are having cardiorenal syndrome. So these two drugs can be given with patients even if diabetes is not present. Yes, anyone has any doubts?
No, ma'am.
Okay. Okay, so SGLT2 and GLP-1 are the two classes where the drugs, even if the patient is not having diabetes, can be used. Also, among the very old players of diabetes, metformin is one drug which is used as well as in diabetes, but other benefits also. Can anyone tell me, in females, we use metformin for what?
In PCOS, it is
PCOD,
used.
ma'am.
PCOD,
As
ma'am.
Yes,
PCOD.
perfectly. For PCOS, we can use PCOS or PCOD. Metformin can be the drug of choice. First, it was off the label. Now it is officially can be used. Okay, so now let's go ahead. As everyone has seen the classification of the anti-diabetic drugs, let's go ahead. Okay, so this chart tells us if the patient has diabetes plus the comorbidities, what will be your first line of treatment? This is very important considering all the clinical scenarios that you get. You have to remember this. First, if the patient has diabetes with CKD or any kidney disease, as we know, the drug of choice should be Ramipril. If Ramipril not there or if it is not tolerable, then you can go for SGLT2 inhibitors. That is your dapagliflozin, empagliflozin. Okay. If the patient has cardiovascular diseases as well as diabetes, what will be the first line of drug? GLP-1, that is your tirzepatide or your another SGLT2 semaglutide. And then you can again go with SGLT2 inhibitors, empagliflozin, dapagliflozin. Okay. Then you have heart failure. Just give me a minute. I'm having a disturbance. Wait. Okay, I'm so sorry for the disturbance. Yes, so I was telling that if the patient has CKD, or sorry, heart failure as well as diabetes, the first line of drug is also going to be SGLT2 inhibitors. If you want weight loss with diabetes, again GLP-1 and SGLT2, CKD with diabetes, SGLT2. So all these medicines, basically the most dominant part here is SGLT2. And currently, according to all the international guidelines, SGLT2 is the most popular drug because it has a cardioprotective, renoprotective, as well as the endocrine protective axis as well. Okay. Yes. So I guess everything was clear about this. Any doubts about ACE inhibitors?
No,
okay,
ma'am.
ma'am.
All
Okay, fine. Okay, so the next question. A hypertensive patient develops facial swelling, lip edema after starting the drug 3 days ago. What is the most likely drug? Amlodipine, enalapril, atenolol, or furosemide? Kindly post your answers. Okay, so I'm getting answers like amlodipine. Dr. Rabia says amlodipine. Then Dr. Oluwakemi is saying B. Dr. Rabia says B. Dr. Sahila is saying B. Mifra is saying A. Okay. Yes. So, Dr. Mifra, can you please tell me why would you think that A can be the answer?
Mhm. I'm not sure about the reason, ma'am.
Okay. Dr. Zulekha, can you explain me your answer, please?
Ma'am, answer B.
Ma'am, I thought, can I?
Y- Yes, let Dr. Zulekha complete Dr. Rabia. 1 minute.
Okay.
Yes.
Ma'am, I think it is the anal SE inhibitor.
Okay. What is this image? What is this image showing? What this condition do we call it as?
Name of condition I didn't remember, ma'am.
Okay. Fine. No
Means,
problem.
ma'am, this
Yes,
is
Dr. Rabia.
angioedema. This is
Okay.
angioedema.
Yes.
Angioedema.
Angioedema
Okay.
because of bradykinin release.
Initially,
Okay.
I was thinking amlodipine. Then I saw the picture. Then I think this is
Yes.
angioedema.
Yes, the picture is for you people.
Amlodipine causing generalized swelling, but typical angioedema caused by ACE inhibitors.
Okay, perfect. Yes, all the doctors, you're correct. The answer is B, enalapril. And the image that I have shown here, it is angioedema. Okay, 1 minute. Why is this not writing? Okay. So this is what? This is angioedema. Angioedema, although the word comes angio, it is not exactly anything related to the heart or cardiovascular, but it is something as an anaphylactic type of reaction where you get swelling of the lips, swelling of the eyes, then you get laryngeal edema. It is an allergic type of a reaction, or you can call it as a hypersensitivity type of reaction. And this is very common with ACE inhibitors. Okay, so when we talk about ACE inhibitors, now let us see what are the side effects about ACE inhibitors. Here, due to the bradykinin release, yes, Dr. Sahila, you were right, due to the bradykinin release or bradykinin accumulation, it is going to cause you angioedema. And the main part, it is not only the first dose. See, there are two types of reactions. One is late and one or delayed, or one is somewhere which is having an intermediate onset, and one is an acute onset. It won't happen that the patient is taking first pill of his ACE inhibitors or ramipril is taking first time and he gets angioedema. No, he can maybe develop it after 1 month, maybe he can develop after 5 days, or he can develop after 10 days. Okay, so basically this reaction can occur at any moment due to the bradykinin amount, whatever is getting accumulated in the body. Bradykinin, as everyone should know, it is an inflammatory mediator which causes this hypersensitivity type of reaction. Then coming for the mechanism of action of this ACE inhibitors, that is your bradykinin mediated or a immediate inflammatory mediator release. Okay, and due to this, the angiotensin is going to get converted to angiotensin 3 and the efficiency of the ACE inhibitors is reduced. So what should be the next step for doing this? We should be replacing the drug with ARB, or we can replace the drug with CCB depending on the other conditions. But the image that we have shown you here, that is of angioedema itself. Sometimes it can occur more severe with swelling of the eyes as well, eyes as in the eyelids. And sometimes the patient can only come to you with respiratory discomfort. And when there is respiratory discomfort, always remember it can be a laryngeal type of edema. Cough will also be one of the symptoms that the patient is showing. Okay. Yes, just out of this question, can anyone tell me if the patient has pedal edema, what will be the drug that will be causing the pedal edema among the antihypertensives?
Amlodipine.
Okay. Yes, Dr. Noshin, you're correct. It has to be.
Thiazide. Okay, okay.
Yeah. Yes. So amlodipine will be the calcium channel blocker, which is most commonly used drug, but can cause pedal edema. Okay. Yes. Coming to the next slide. 1 minute. Yes. So now when ACE inhibitors we are talking about, there is going to be ACE cuff, that is angiotensin converting enzyme related drug cuff. The answer, the causative agent for this cuff is bradykinin. Angioedema is there. Again, bradykinin is the same answer, but you have to stop the drug immediately and replace it with ARB. Alternative for ARB, always safe, anaphylaxis swelling, adrenaline, intramuscular should be given if there is more or severe type of anaphylactic type of reaction. Okay, so this is all in one side effects about ACE inhibitors that you should be knowing. What is it? It is going to be cough, angioneuritic edema, proteinuria, taste disturbances, fatigue and headache, potassium increase, hyperkalemia, renal impairment, itching, and low BP. All these are the side effects you can remember with the mnemonic captopril for your ACE inhibitors. Okay, so now I'll just ask you a question. For example, there is a 54-year female who's already on ACE inhibitors. Okay, that time later on she is having her potassium levels of 1 minute 6.4 and her
Ma'am,
BP.
excuse me.
Yes,
Ma'am, actually, this course is for GP or like it is for internal medicine, ma'am?
it is for GPY.
Okay, ma'am. Actually, I'm preparing for OMSB internal medicine, ma'am. Do you have a course for that?
We already have courses for that, but the knowledge that you're getting from this test is useful overall for any of the exams that you will be giving, the screening ones. Because
Okay,
the
ma'am. How to
basic
take
things,
subscription, ma'am? Like internal medicine, OMSB, how to take, ma'am?
you can connect with Dr. Munjal sir on his personal number. The number is displayed on the screen and we'll give you the details about it.
Okay, thank you, ma'am. Sorry to disturb.
No worries. Okay, so coming to our topic, I was saying that it is a 54-year female, ACE inhibitor. She's already taking ramipril 5 mg. You can consider potassium level is 6.4 and she develops taste disturbances. Okay, so what will be your drug of choice? What will be the treatment that you will be giving her? Should we
Immediately
continue
stop.
ACE inhibitors
No,
or
ma'am.
should we
Immediately
increase the
stop.
dose? Stop it.
Ma'am, immediately stop.
Why?
And
What is the
first
reason?
first
Potassium
immediately
first.
stop for depotage the patient, then think about that drug.
Okay, fine.
6.4 potassium.
Okay, very good. As we know, the side effects of ACE inhibitors, one of the major life-threatening side effect is potassium increase. So if the patient has 6.4 potassium, it's absolute contraindication that we should be continuing the ACE inhibitors. Instead, go ahead with ARB or
ARBs or
go ahead with
thiazides.
CCB. Okay?
CCBs. Okay.
Yeah.
Why not thiazides, ma'am?
Thiazide immediately we won't indicate because it is 54-year-old patient and the BP is maintained. If there are any
Okay.
signs of edema, then we can start with thiazides. See, thiazides
Okay.
basically, they just remove the fluid from the body. So in case if the
Okay.
patient has some signs of pleural effusion, some signs of pericarditis maybe, or fluid overload or pedal edema, then I can say that we can start with thiazides. Okay?
ARBs also will cause hyperkalemia, right, ma'am? No.
No, ARBs don't cause hyperkalemia. That's the one very much potential effect of ARBs that they do not disturb your potassium levels.
Okay. Okay, ma'am.
Yes. Okay, so I guess it was clear about side effects of ACE inhibitors.
Yes, ma'am.
Okay, perfect. Now one revision question. If the patient has cardiovascular, that is heart issues as well as diabetes, what will be the first line of drug
For
for diabetes? For diabetes.
SGL2
Very good. So it is SGLT2, not
to
SGL2, SGLT2.
SGLT2. Yeah.
Yes. Okay. All right. Now, the next question. 60-year-old with stable angina. Okay. So keep in mind, it is 60-year-old with stable angina. Okay. Uses sublingual nitrate daily multiple times. Now, the nitrates is showing less effect. What is the reason? First, drug resistance, then tolerance due to continuous nitrate exposure, increased metabolism, or increased renal excretion. Read this question carefully and please post your answers.
कार के अलावा ऐसे राइड करने का भी मजा है तुम्हारे नेल्स देखो कितने बड़े बड़े हो गए
हाँ यार,
लाइक हो तो बैठे बैठे
Angina is supplement daily multiple times.
Okay, so what are the answers? A bit tricky question. That's the reason I told you take some time. Okay, so let me help you. It is 60-year-old patient, stable angina. You don't have to worry about it. Then uses sublingual nitrate daily for multiple times. So maybe 3 times. and now it is showing less effect. Firstly, you can just think about pharmacology and you can think that it can be the drug resistance or it can be due to continuous nitrate exposure. It cannot be increased renal excretion and it cannot be increased metabolism. So either A or B. I've just
It's B.
shortlisted two options.
Yes, ma'am.
What can that be? Okay, majority of people are saying B. Yes. Okay. So let us see what exactly is the answer. Okay.
B.
Okay. Yes, everyone is correct. The answer is B. The clinical diagnosis for this is a stable angina and which is on a chronic nitrate therapy, which rarely or majority of the time can cause nitrate tolerance. That is, the nitrate is going to show you lesser effect if it is taken chronically. Okay.
Yes,
That
ma'am.
means the more nitrates you take, the lesser effect it is going to show. For this, what you have to do, you have to give it a time of 12 to 15 hours. That is what you can call it as a nitrate holiday or a drug holiday. You must have considered this, must be aware of this term, that a nitrate holiday or a drug holiday. Drug holiday is what? You have to,
Dr. Akankssha, sorry to interrupt you.
yes,
It's 8 to 12 hours or 12 to 15 hours?
12 to 15 hours.
Okay.
According to the ESC 2024 guidelines, it is 12 to 15 hours.
It's a previously we used to 8 to 12. Okay.
Previously, it was 8 to 12. Currently, it is 12 to 15 hours.
Thank you very much.
Yes, the European Society of Cardiology, you can anytime refer to the guideline. The current ones, that is the ESC 2024, is the recent publication that has come. It is 12 to 15 hours. Okay. Yes. So, coming, where were we? Yeah, we were on the nitrates part. Now, the drugs of nitrates, they are generally being given as a long acting and a short acting. The long acting ones in the form of isosorbide dinitrate or isosorbide mononitrate or the patches, which are very popular internationally as well as in India. So the GTN patches, they deliver the drug for almost 10 to 12 hours and they have the typical onset of delivering and they can stop themselves. So the patches are the most ideal things that can be given instead of the oral nitrates to the patients. Okay, so now let us see why the nitrate tolerance develops. So now the patient is taking nitrates repeatedly or continuously. That can be a patch, a long acting one, over days, weeks, same doses, but lesser hemodynamic effect. What is the reason for this lesser hemodynamic effect? The reason is the nitric oxide does not get converted. This nitric oxide does not get converted. There is no reduction of this and it increases the oxidative stress or what you can call it as a superoxide, which inactivates your nitric oxide. Okay, so this is also one liner that they ask you in the exam. The superoxide gets the inactivation of the nitric oxide during your nitrate tolerance effect or the lesser hemodynamic effect phase. All right. Then you go in for the exact mechanism of action. What will be the mechanism of action here? The nitrates, they are not donating nitric oxide, but this is not getting converted to the nitric oxide results that we want, which in turn does not cause the smooth muscle relaxation. And whenever you talk about nitrates, always remember nitrates cause a venodilation more than arterial dilation. So the nitrates, they affect on the veins more as compared to your arteries. So whenever you give patient a nitrate, this is going to affect more on the veins as compared to your arteries, especially the collaterals. The collaterals that everyone knows, this is a vein and this is an artery. There are some collaterals which getting supplied by both the ways. So this collateral circulation, this is acted upon by the nitrates. And whenever you give nitrates, this is going to be giving the dilation of the collaterals. Okay. So therefore, venodilation is going to be more, reducing the venous return, reducing the preload to the heart, and then reducing the left ventricular stress. So another one liner you should know, the nitrates, they act on the venous return and reduce the preload and they do not reduce the afterload. So nitrates always reduce the preload and reduce the venous return. Therefore, what is going to happen? There is going to be coronary vasodilation, relief of spasm. That's the reason that in angina, nitrates are going to act very faster within maybe 15 to 20 minutes. What is the side effect of this nitrates? Due to the venodilation or the vasodilation, what to talk, there is going to be headache and flushing, hypotension, syncope, reflex tachycardia. Okay. And sometimes, very rare, it can cause methemoglobinemia. That is also one of the questions that they ask. Methemoglobinemia can be caused due to the nitrates. Now let us see what exactly is the mechanism of this. See here, just like I told you, the collaterals with the nitrates, this collaterals, they are more dilated and the circulation is distributed. The preload is affected properly. Now here, look at this. The collaterals are not having any circulation. There is fully dilated arterioles, normal tone arterioles, but the blood is not getting here. Once you give nitrates, there is equal distribution. The left ventricular stress, that is reduced. So this is the way that nitrates are going to act. And nitrate tolerance, how do we have to maintain that? We'll see that now. Okay, so if the patient has nitrate tolerance or the patient is not having a proper working of the nitrates, what will be the next add-on drug? The next add-on drug will be beta blocker or CCB for the baseline control. So sometimes you have to give nitrate-free interval for 10 to 12 hours or 14 hours as per new guidelines, 10 to 14 hours, 14 hours. And how to prevent the tolerance? First, you can give one beta blocker, that is metoprolol, that is the drug of the choice, and amlodipine for the baseline control. If that not, then what you can give? You can give, if it is a stable angina, you can give beta blocker plus minus calcium channel blocker. Again, another drug that you can give is antiplatelet plus statin. That is, you can give aspirin plus rosuvastatin for the coronary artery disease protection. Okay. And the fourth scenario, if it is a variant angina or a Prinzmetal's angina, what you can give? You can give morphine, which is going to be causing the pain at the rest. And if there is a transient ST elevation, you can again give antiplatelet and the statins. Now, if there is CCBs, you have to avoid CCBs. Where you have to avoid CCBs, just like can anyone tell me where do we avoid CCBs? I'm getting the answers or not here. Let me see.
Cardiac failure, ma'am.
Yes, right. Cardiac failure or heart failure with reduced ejection fraction, you can avoid CCBs. Very good. Dr. Oluwakemi, you are asking me that what is 12 to 15 hours? 12 to 15 hours is the interval, not 15, but 10 to 14 hours or 12 to 14 hours is the interval where we give nitrate-free interval to the patient. That means do not give any nitrates for the next 12 hours, but replace that time with one beta blocker tablet or a one calcium channel tablet, because we have to give a drug holiday to the body to allow a better metabolism or a better action of the nitrates in the coming time. So frequent taking of the nitrates, it is going to reduce the drug metabolism or it is going to increase the nitrate tolerance in the body. Okay, so I hope this is clear. Just 3 pointers we learned from this. First is the tolerance. Yes, first is the tolerance. To clear the tolerance, we just have 3 ways. One is the beta blocker that we are going to give. Second is the CCB. And third is we have to wait the interval 12 to 14 hours. Okay. With all of this, just remember nitrate tolerance. And then if it is too much of dose, reduce the dose as well as replace it with beta blocker or calcium channel blocker. As simple as that, considering your exam. Okay, coming to the next question. Any doubts for the nitrates anyone has? You can please post your answer or just unmute yourself and talk.
No, ma'am, all clear. Thank you.
Okay, perfect. Okay, so hemodynamically stable monomorphic VT in the emergency room. What is the next drug? Adenosine, amiodarone, verapamil, or digoxin. Take 5 to 10 seconds. Before that, you have to tell me what are the, 1 minute, what are the types of VT? And what is the drug of choice in them?
Ma'am, we have pulseless VT and with pulse VT, and also stable hemodynamically stable VT and unstable VT, ma'am.
Okay, very good. That has kind of good answer. And what are the drug of choice everywhere that you know?
Ma'am, other type is monomorphic VT and
Monomorphic and
polymorphic
polymorphic VT.
Okay.
Adenosine.
Yes, Dr. Nahid, what are you saying?
Adenosine. We need to give adenosine, yeah?
Adenosine.
No.
Okay, perfect. Okay, thank you students for the input. Just let us get to the answer. The answer here, as it is a stable monomorphic VT, the drug of choice for this is IV adenosine.
Why,
Yes.
ma'am?
Anyone has any doubt?
Yes, ma'am.
Yes.
Ma'am, adenosine is in supraventricular tachycardia only, ma'am. SVT only adenosine.
Okay.
Why not amiodarone, ma'am? Amiodarone. I thought it's amiodarone.
Yes. 1 minute. It is amiodarone. My bad.
Amiodarone, ma'am. Palm.
Yes, ma'am, we are
Ma'am,
thinking about it.
amiodarone.
Yeah, I have
Sorry,
gone
sorry, my
for
bad.
amiodarone.
Yes, my bad.
Yeah.
Thank you for noticing this.
Okay.
So I was thinking of all the types of VT that I have to write. I was in confusion, sorry. The drug of
Okay.
choice here has to be IV amiodarone.
Amiodarone.
Yeah, because it is a stable one.
Stable
If
VT.
it
Yeah.
is, yes, if it was your, what you can say,
Supraventricular tachycardia.
PSVT, then we can give adenosine.
Adenosine. Yeah.
Yes, right. So now when we come for the type of the VTs, it has to be a stable monomorphic VT. Then you have ischemic. Ischemic VT is something which you see along with MI at times. Yes, fascicular block that you can see with your right branch bundle block or your left branch bundle block, which is your fascicular VT. Then you have your torsidis de pointis. Then you have your electrical imbalance VT or your electrical storm VT. And one more thing. Okay, fine. Polymorphic VT, I don't need to tell you. These are all other types of polymorphic VT only.
Ma'am,
Stable,
one more
monomorphic.
bidirectional VT.
Okay. Bidirectional is also there. Or you can see that RVOT VT is also there. What is RVOT VT?
Right ventricular outflow tract obstruction.
Yes, very good, Dr. Saila. So it is RVOT VT. The drug of choice for stable monomorphic VT is going to be amiodarone.
Amiodarone.
Yes, amiodarone, but considerably it has to be IV and almost loading dose has to be 120 milligram or a 90 mg bolus. Okay. Then if you talk about ischemic VT, the drug of choice has to be lidocaine. Lidocaine. If lidocaine not available, then again amiodarone.
Amiodarone.
Yes. Fascicular one, it is there. That is your branch bundle blocks. What has to be? It has to be your verapamil. That is your calcium channel blocker. Okay. Then you have your torsidis de pointis. What will be the
Magnesium
drug
sulfate.
of choice?
Magnesium sulfate.
MgSO4. Magnesium sulfate. If it is your bidirectional VT, the drug of choice again can be your amiodarone or lidocaine. And if it is your RVOT, that is right ventricular obstructive one, the drug of choice has to be beta blocker. Okay. So this is very important. Just one-liners they can ask directly in the exam or they can show you a ECG. What is the type of VT and what is the drug of choice that you will be using in them. Now here why IV amiodarone was a correct option, because there is going to be the wide complex regular tachycardia where we can say that it is a VT and the patient is hemodynamically stable. So whenever there is a stable VT, the antiarrhythmic of choice has to be amiodarone or procainamide depending on whatever ICU protocols that you follow. And if it is an unstable VT, immediate synchronized cardioversion. Okay. So can you tell me what is the power that we use for the cardioversion? What will be the electrical impulse power?
150 joules.
Okay, any other answers?
Ma'am, 150 to 200.
Okay, and how many cycles you can give? Maximum, what will
Three,
be the
three, three, three
Three
cycles.
3 cycles? Okay, so can you give 400 joules also if needed?
I think not.
Has anyone done cardioversion code blue at the hospitals?
Yes,
Yes, ma'am, I have done many times, but we will go up to 300, not more than.
Okay, okay, fine, understood. So the thing is that cardioversion you can go between 150 or maybe 200 to 400 is the standard one depending on the response of the patient. You said right, it can be given for 3 cycles. Okay. Now, coming to the classification of antiarrhythmic drugs. Now, what are the antiarrhythmic drugs that you should know depending on the class and what is their mechanism of action? So, there are totally 5 classes, or you can say there are 6 classes ideally, but class 5 we don't consider clinically important. Class 1, 2, 3, 4, and 5. Okay. So coming here, class 1, you will have sodium channel blockers. It has to be your lidocaine, flecainide, and propafone. What is the mechanism of action? See, sodium causes excitation. So that these channels, these drugs, they are going to block your sodium channels and they are going to cause slow depolarization. You must be knowing this action potential graph. Okay, so this is a negative impulse. It is coming from here and then it again goes here. So this depolarization, this part, that is your excitation. This is caused by the sodium influx. Now this sodium influx is going to be blocked by your what? Sodium channel blockers, lidocaine, flecainide, propanophone. And therefore we can use class 1 antiarrhythmics here. Class 2 beta blockers, this is metoprolol, atenolol, esmolol, very commonly used. What do they do? What is the mechanism of action? The main thing you should know is they reduce the beta adrenergic activity and they reduce the heart rate. So they can be the drug of choice in tachycardia. Coming to the potassium channel blockers, you have amiodarone, sotalol, dofilide. What do? They block the potassium channels and they prolong the repolarization phase. So for example, this is depolarization, this is repolarization. This repolarization phase, this has to be prolonged. Here one is acting and here one is acting. In the physiology basic mechanism, you must be remembering that is the sodium potassium influx pump. Now this is going to be acted by the class 3 antiarrhythmics. Then you have the calcium channel blockers, another molecule which is responsible for your excitation. It is again going to block your calcium channels. Okay, and slows the conduction of the heart rate. The calcium, it is coming from the T tubules, and this T tubules, it is going to cause the contraction of the heart muscles. Now this contraction can be reduced with the help of this calcium channel blockers. And then there is verapamil diltiazem, again calcium channel blockers, which is going to have the same effect, that is slow conduction of the heart rate. Okay, so if it is a sustained monomorphic VT, which is ventricular tachycardia, the drug of choice, as we know, that was amiodarone. Then another drug of choice here we have is the procainamide or lidocaine. Sometimes lidocaine, as we have seen, can be given in the ischemic VT, whichever is having with MI, and still there is a VT. Then you can give, or maybe the drug of choice has to be lidocaine. Amiodarone, how does it act? It has a multiple channel effects. Firstly, it blocks your potassium channel. Then it affects your repolarization. That is, it increases the duration of your repolarization and increases your refractory period. Now, what are the side effects of amiodarone that you should know? First and foremost is pulmonary toxicity, that is fibrosis. There is thyroid dysfunction, hepatotoxic, corneal deposits, photosensitivity, skin discoloration, and prolonged QT syndrome. Prolonged QT, again, one of the major side effects of your amiodarone. So, for example, if I have a patient with cystic fibrosis and she is having VT, okay, the same one, monomorphic VT. What drug of choice will you give her? Will you give her amiodarone or what you should give her?
Calcium channel blockers, ma'am.
Okay. Which other?
Beta blockers.
Beta blockers. Okay. You can also give her procainamide. Okay.
Okay,
So,
ma'am.
in case amiodarone is not suitable in a patient, or maybe the patient has liver cirrhosis, the patient has Wilson's disease, too much of corneal deposits of copper, you cannot play with that condition clinically, you can give procainamide or flecainide in case amiodarone is contraindicated in the patient. All right. Any doubts about antiarrhythmics?
No, ma'am.
Okay.
Me, hello.
Anyone? Yes.
Gee, I need to know that why first we have rejected adenosine. Can you tell me also the reason? Because that is also one type of ventricular tachycardia. Yes. So why we have rejected this? What's the reason? Thank you.
I do not understand your question, Dr. Nahid. Can you repeat?
Why
Adenosine is
it is not the adenosine?
okay.
Why it is wrong answer? Can you tell me about that? Because there is a one adenosine that is a drug treatment therapy for
Okay.
ventricular tachycardia.
Okay. So basically, see, adenosine, it is given in case of ventricular fibrillation, which is more into, see, the ventricular tachycardia, which can land into ventricular fibrillation, we can give adenosine there. But considering this scenario,
Yes.
that it is a stable, hemodynamically stable patient, which cannot land into ventricular fibrillation, right? So here, what is the line that we should know? Amiodarone should be the drug of choice.
Got it.
This one.
Thank you so much.
Okay.
Ma'am,
Any other questions?
if it lands into VF, it should be treated with
Adenosine and cardioversion.
Yeah, cardioversion.
Yes. Any other doubts? We are good to go ahead? Okay, someone saying anything?
Yes, ma'am.
Okay, fine. Okay, so there are 2-3 clinical scenarios. If everything is hemodynamically stable, everything is fine, you can give synchronized cardioversion, plus if it is a pulseless VT/VF, defibrillation, CPR, adrenaline, and amiodarone, if it has to be along with your adenosine. Now, irregular versus regular wide complex tachycardia, the drug of choice has to be amiodarone. Again, if there is going to be any wide complex tachycardia, procainamide can be given if the patient cannot be giving amiodarone. Torsades de pointis with twisting QRS, prolonged QT, what will be the drug of choice? Magnesium sulfate. The same thing I have explained in the first slide, types of VT and what will be the drug of choice. Okay. Now coming to endocrine, in DKA patient, what will be the insulin of choice? Subcutaneous rapid insulin, IV regular insulin, NPH insulin, and insulin glargine. Before you tell me the correct answer, I want you to tell me the types of insulin as well. Okay. Everyone's saying IV regular insulin. Perfect. Everyone's very smart in our group. The correct answer is IV regular insulin. So, what is insulin glargine? Can anyone tell me what type of insulin is insulin glargine?
The long acting.
Very
Oh,
long.
Long acting.
okay. And which is the longest acting insulin?
Lantus.
Lulation.
Glargine.
Rhizodec.
Longest.
Which
What is Detemir?
Datamir.
Long acting, ma'am.
Yes.
Degludec.
Yes, degludec. Right. So that is the longest acting one. Glargine is a longer acting, no doubt, but someone has come for giving a competition to glargine as well. Glargine is Lantus, the most common name. And degludec is, which is more longer acting than your glargine.
Is Rhizodec the same?
That's the brand name, if I'm not wrong.
Yes, that's
Yes.
Okay.
I think it's Decludec. It's a combination of Decludec and
Tresiba, I guess. Tresiba is
Tresiba is the longest acting
Long
brand
acting
name. Yeah.
brand name. Yeah.
See what happens, as doctors, we practice clinically. Sometimes we are so well versed with the brand names that we forget
Yeah,
the original
exactly.
molecule name.
Seriously.
Majority of the time, I've seen doctors, sometimes we forget, we write direct Lantus, but we don't know what molecule is Lantus insulin. Okay, so
Yeah.
coming to our answer. Everyone is given the right choice. Now, in DKA, what is the major thing that is happening? In DKA, the patient has a absolute insulin deficiency. So therefore, DKA is a major complication of type 1 diabetes, not the type 2. Glucagon is increased, lipolysis is increased. Why? The breakdown of the fats is more, and that's the reason you have ketone deposits in your urine, or ketone bodies are accumulated in the body. Why? Because too much of fat degeneration is there. Hepatic glucose output is increased and peripheral glucose uptake is reduced. So these are all the mechanisms for your DKA, as in what is exactly happening inside the body. Due to this, there is going to be hyperglycemia, metabolic acidosis, that is, pH is one of the factors that we see while discussing DKA, osmotic diuresis, and severe electrolyte shifts. Major molecule to be affected in DKA is the potassium, that you should be very careful about. Then you have the IV regular insulin, that is the correct answer. Why? Because we have to take the immediate action. It can be used for titration and control. We do not have to be like we have given the insulin and we have to wait for the action. No, we can take the action as per the requirement and as per the dose. It has the ability to stop instantly if hypoglycemia occurs, or if the potassium values they drop. Okay, so therefore the IV insulin is our correct answer. Now let us see the explanation more. Yes, so whenever there is DKA, the hepatic gluconeogenesis is going to be affected. You give IV insulin, the regular insulin that you call it as. Then it is going to reduce your hepatic gluconeogenesis, reducing the glucose in the blood sugars. Then lipolysis is going to be reduced, therefore the ketone bodies, that is your alpha beta this is going to be reduced. Also your potassium shift is increased and the risk of hypokalemia at times can increase. Proteolysis is reduced, therefore the catabolic state, as you know that the decay is a catabolic state, that state can be corrected when you give IV regular insulin. Now, this is the ideal flow chart, or you can say the treatment algorithm. Whenever we see that there is a DKA, what do you see? You see whether the pH is acidic or it is basic. If the pH is acidic, then we have to infuse 1 to 2 ampules of NHCO3, correct your pH first. Then if the potassium, it is less than 3.3, what do? You replace the potassium. If not, then you start with IV bolus infusion. So basically, before seeing this algorithm, what is the first line treatment of DKA? What should be done first?
Fluids.
Is
Fluids.
insulin first or is hydration first in the
Fluids.
patient?
Hydration.
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 Okay, perfect. So this answer is very correct, that hydration is very first in the patient and not the insulin. Don't rush to reduce the blood sugar levels. No, that is not recommended. First, you should be rapidly hydrating the patient. That is, you have to give NS. NS should be given at how much?
2 liters in 30 minutes.
Okay, fine. So you can consider giving bolus of normal saline. That is, you can give almost 2 pints in first 15-20 minutes, and then you can start off with the next 1 liter in the next 1 hour. Okay, that depends on hospital protocols as well, but rapid hydration is very much important along with sideline correction of your potassium. These
Potassium.
two things. Once hydration and once potassium correction is done, then go ahead with the blood glucose levels that you have to start on maintaining. During maintenance of the blood glucose levels, you have to give insulin at 0.1 unit per kg of that patient. Out of that, first 10% needs to be given in the 1 hour, and then you can give whatever is required to get the blood glucose level between 200 to 250. Ideally 250 in clinical practice, but if as per the book you go, it has to be till 200 or not less than 200. Not immediate hypoglycemia should be done in the patient. Okay? All right. Now I'm not going to explain this. DKA we have already done before. Okay, so before I jump on to the next question, can anyone explain me what exactly in DKA will we be doing and how do we manage DKA? What should be the what you say, the complications that we should be worried about in a DKA patient? Anyone?
Overcorrection of cerebral edema, the fluids management.
Okay,
And risk of hypokalemia.
Hypokalemia.
okay. So what should be the potassium levels that we need to be maintaining in patient of DKA?
3 to 5.
It's above 3.5.
Okay, fine, perfect.
Ma'am,
So
I
the
have a
potassium,
question. Ma'am,
yes.
I have a question. If patient is suffering already diabetes with cardiac patient, like low EF,
Hmm.
then our management should be also with 2 liter rapidly?
We have to see for the hydration status. It shouldn't be that we are giving fluid overload so much that the patient can get cerebral
IBC.
edema. That
Yeah.
times you can check for 1.2 liters in the first 2 hours.
Okay.
Okay.
Okay, ma'am.
So over resuscitation sometimes can cause your cerebral edema, pulmonary edema. So for that, what do you have to give? We have to give it in a very controlled manner, not just like the random patient which comes with DKA for us.
Okay, ma'am.
Yes. Any other doubts?
No, ma'am.
Okay. Now, what will be the drug of choice if the patient is already having heart failure and comes with DKA? So, what drug of choice should be there? Oral drug that you should be giving while continuation.
SGLT2, dapagliflozin.
Very good, Dr. Saila. Right answer.
DAPA जो है DAPA.
Yes, right. Empagliflozin or dapagliflozin. All right. Should we move on for the next question?
Yes, ma'am.
Okay. So, a obese patient with type 2 diabetes mellitus has high HbA1c, normal renal function. What is the first drug of choice? Sulfonylureas, metformin, insulin, or pioglitazone? Okay, so everyone's saying the answer is metformin. Very good. Can anyone tell me why metformin?
Metformin inhibits gluconeogenesis,
Okay,
and it helps with the obesity. And
okay,
with metformin, we also have to guide the patient about diet and exercise.
very good.
No risk
Perfect.
of hypoglycemia, ma'am.
Yeah.
Okay, very
Gastric
good.
emptying, it will slow.
All right. Fine. Understandable. Very good. The correct answer is metformin. Let us go ahead. Now, here, why metformin we are giving? Because the patient, he's obese. Obese means there can be insulin resistant dominant type, right? Hepatic glucose overproduction because type 2 diabetes is there. Adipose tissue lipotoxicity is there and chronic inflammation can be there. Therefore, the metformin has to be the first line drug. With this, what are we going to happen? What is the target that we are going to achieve? We are going to reduce the sugar productions or glucose productions from the liver, increase the peripheral insulin sensitivity, and reduce the intestinal glucose absorption. Okay. Along with that, along with this metformin main characters that we see, the bonus is going to be weight loss, cardioprotective risk, and low hypoglycemic risk. So, as very well answered by all of you, these are the main reasons that metformin will be the first line drug that we can give. What is the safer dose of metformin?
Ma'am, it can use up to
3 grams
250
per
mg
day.
till 3,000 mg.
Okay. The safer dose in young patients, 1 minute. The safer dose in young patients can be till 4 gram per day, but for a short period, not too much. In older patients can be 2 grams per day. But if the patient has CKD or the patient has AKI or any nephrocauses, then the patient can only be given 1 gram if required. So, in renal patients always give carefully metformin. Keep this always in mind. Okay, reduce the dose. If there is a CKD patient and he's taking 2 grams of metformin already, just reduce the dose and you will see the renal benefits. And therefore, in this patients who has CKD but who has very high dose of metformin, we have to replace the drug. What will be the drug now? Yes, what will be the replacement of this drug?
Dapagliflozin and
SGLT2.
dapagliflozin.
Yes, again the same answer, SGLT2 inhibitors. Or you can give DPP4. What are the DPP4?
Sitagliptin.
Yes. Anyone else?
EMPA.
How about GLP-2 inhibitors? GLP-1
GLP-2 inhibitors, fine, they can work. DPP4 inhibitors are your sitagliptin, linagliptin. Okay. So DPP4 inhibitors, they are also very safer considering your renal mechanism. And cardiorenal, SGLT2. DPP4, SGLT2, both can be given in renal protective mechanism. Okay. That is your sitagliptin or your linagliptin. Right?
Okay, ma'am.
Yeah. Okay, so this is the basic mechanism of action for your metformin. It is going to activate which pathway? It is going to activate your AMP pathway, that is your cellular energy sensor pathway. Okay, it is going to reduce your hepatic glucose production, reduce the lipogenesis. Therefore, this effect is going to be on obesity and therefore weight loss will be there because it reduces your lipogenesis. And there is going to be gut microbiome effect, that is the oxidative stress as well as your inflammatory cytokines, they are also reduced in your metformin therapy. But where should we stop our metformin therapy? The EGFR has to be below 30. The sepsis is there, the shock is there, and severe hypoxia is there. These conditions, they are the contraindications. Never give metformin in kidney disease, sepsis, shock, or hypoxia. Okay, so just remember this. This chart we have already discussed the other part of the slide. Okay, so I hope this question was clear for all of you. When do we use metformin and where do we not use it?
Yes, ma'am.
Okay, perfect. I see many participants here, but only 3 to 4 are answering. I want everyone to be a part of this. Hardly we have left with, okay, last 5 minutes. I'm just taking this question ahead. This is a different question. Okay, the last question for today. A young athlete develops Achilles tendon rupture after antibiotic therapy. What is the most likely drug to cause this? Amoxicillin, ciprofloxacin, doxycycline, or linezolid? See here you see
Ciprofloxacin.
tendon rupture.
Ciprofloxacin.
Okay, Dr. Sahila is saying ciprofloxacin. Let me see the answers. Okay, everyone's saying B. Yes, correct, my dear students. The correct answer is ciprofloxacin because Achilles tendon rupture is a very common complication of your fluoroquinolones. So when we talk about your fluoroquinolones, it is your ciprofloxacin, which can be the most common causative agent. Okay, so fluoroquinolones, they are just not antibiotics, but what do? They alter your collagen metabolism. They cause oxidative stress in the tenocytes, that is in your tendons, whatever the cells are there. The cells which are developing the tendons, they cause oxidative stress and they cause your tendon to become weaker. Cellular mechanisms, they are reducing the type 1 collagen synthesis which is present in the tendons and ligaments. It is going to reduce the tendon repairability and increase the matrix of the metalloproteinase activity. Just remember the words, don't need to remember so much in detail. Why the Achilles tendon is the most common to get ruptured? The reason being, it is very poorly vascular, it has high mechanical stress, and it has a slow healing environment. So in our question, what was the main keywords that you should know? A young patient and an athlete patient. Athlete means already his part, already this Achilles tendon, it is going to be overused, right? So it is very important. So when it is overused, there is also high mechanical stress here. poor vascularity, and slow healing environment. That is the main reason that the fluoroquinolones has caused this rupture. Now, who are the risk for this? Elderly patients, steroidal use who are on a chronic steroid therapy, someone who has autoimmune condition, renal diseases, and athletes. Okay, so what are the fluoroquinolones? The fluoroquinolones, they are going to inhibit, they are bacteria inhibiting DNA gyrase mechanisms. Therefore, this fluoroquinolones, they cannot be given randomly in anyone, although they are the drug of choice for majority of the UTI. Okay, but we do not give this. What do we give? Instead, what will be the another drug of choice that you will be giving here?
Trimethoprim and
Okay,
Sulfadoxine.
trimethoprim, fine.
Nitrofurantoin.
Nitrofurantoin, very good. Or
Cefixime.
sometimes, yes,
Cefixime.
cefixime,
Cefalexin.
yes,
Cefixime.
and even amoxicillin clavulanic acid. This can also be given. Okay,
Yes, ma'am.
okay, fine. So I'll just ask you 2-3 more. What are the other 2-3 examples of the antibiotics which you should be knowing, which causes a potent side effects? What is the
Chloramphenicol.
potent side effects? For example, if I say it is a gray baby syndrome, which
Chloramphenicol.
antibiotic causes?
Chloramphenicol.
Chloramphenicol,
Very
ma'am.
good. And red man syndrome?
Vancomycin.
Vancomycin, yes.
Very good. So vancomycin causes red man syndrome. Right. And if it is something like,
Rifampicin.
you can say disulfiram type reaction or vomiting and nausea. The highest vomiting and nausea is with which antibiotic? Metronidazole. Okay.
Okay, ma'am.
Yes.
Because it causes
And
hysteria.
yes. And if it is again your ototoxicity and nephrotoxicity, which class?
Streptomycin.
Tetracycline.
Aminoglycosides. Yes, aminoglycosides. That is your gentamicin or your amic acid, your vancomycin. Yes, right. And if it is your tetracycline, as someone said tetracycline, what will be the major side effect of tetracycline? Teeth
Teeth
discoloration.
abnormalities.
Discoloration.
Yes, so if you have a patient who is on a chronic tetracycline therapy, maybe someone who has acne and who's been taking doxycycline for 3 months and who's not stopped, not visited the dermat again, but he's been taking doxycycline for 3 months, he or she can have teeth discoloration. Okay. Anything else? This was about, I guess this was sufficient for today. Anyone has any more doubts?
No, ma'am.
Okay, so now this is a table. I guess you people can take a screenshot for this. Endocrine drug of choice. I have 5 more minutes. So this is the table for endocrine drug of choice. If it is DKA, what will be the drug of choice? Regular insulin, dose, and what you should remember. So these are all the clinical conditions that you should be knowing, just like your severe hypoglycemia, thyroid storm, Graves hyperthyroidism, that is your methimazole will be the drug of choice, which is antithyroid. Mixed edema coma is there. IVLT4. IVLT4 is IV levothyroxine plus hydrocortisone in thyroid storm. Then PTU, propylthiouracil plus methimazole. This will be given. Typical doses also I have mentioned here. Has everyone taken a screenshot so I can move for the next slide?
Yes, please.
Okay. So this is about nephrology drug of choice. So in nephrology drug of choice, what all we have? We have hyperkalemia, hypokalemia, refractory CKD, your seizures in hyponatremia with seizures. See, there is sometimes a syndrome called as osmotic demyelinating syndrome. In here, the sodium levels, they drop very suddenly and the patient, he can go into seizures. That time you give 3% hypertonic saline. You do not give NS, but you give 3% hypertonic saline, and the dose should be 100 ml of 3% saline IV bolus in 3 repeated doses. That is, you slowly correct your sodium by this way. If it is metabolic acidosis in a severe part, what do you give? You give soda bicarb or sodium
Bicarbonate.
bicarbonate. Yes. If it is pyelonephritis, your fluoroquinolones. But in case if it is contraindicated fluoroquinolone, replace it with amoxicillin clavulanic acid or cefixime. Okay. Then you have CKD with proteinuria. Again, you will give ACE inhibitors, ARBs. Ramipril will be the drug of choice. Renal colic, IV isotonic fluids. If it is renal clonic with acute severe pain, we are not going to give any anti-secretory or any antispasmodic drugs for renal colic. It only has to be IV isotonic saline. Okay.
Ma'am, the
Hydration
previous
is the,
slide.
yes.
I want to take the previous slide screenshot, ma'am.
Okay.
Yeah, done, ma'am.
Has everyone taken for this as well?
Yes, ma'am.
Now the last slide for today. This is about the respiratory drug of choice. If it is an acute asthmatic exacerbation, what will be your drug of choice? Salbutamol nebulization plus ipratropium nebulization. Why this combination do we give? Can anyone tell me? Why salbutamol plus ipratropium bromide is given?
They have a cumulative effect because
Yes.
salbutamol is
To causing vasodilation immediately to relieve the symptom.
beta 2 agonist for
Vasodilation or
bronchodilation.
respiratory tree dilation? What?
Bronchodilation.
Tree. Airway
Bronchodilation.
dilation. Yes.
Yeah,
Bronchodilation.
bronchodilation.
So bronchodilation, one is a long-acting bronchodilation and one is a shorter-acting bronchodilator. Okay, so this long-acting and a shorter-acting bronchodilators, one dilates your large vessels, large airway, and one dilates your smaller airways. So this combination is always given. Then if it is asthma maintenance, you give inhalational corticosteroids. Which guidelines do we follow for asthma, by the way? We follow GINA guidelines, GINA guidelines for asthma. Okay, and for COPD, we follow gold standard, GOLD. So gold standard is done for COPD, and for asthma, we follow GINA guidelines. Then, if it is a community acquired pneumonia, what is the drug of choice? Amoxicillin. Amoxicillin plus or minus clavulanic acid depends, but amoxicillin is the drug of choice. If it is community acquired pneumonia, again in outpatient, the same thing. Pulmonary embolism, the drug of choice is anticoagulants. Which anticoagulants? The newer one, the novel ones. The novel anticoagulants we can give apixaban. That is the oral ones. Massive pulmonary embolism, alteplase thrombolysis or tenecteplase thrombolysis can be given. Maintenance can be done with apixaban. Okay. Thank you. Thank you everyone for today's class. I hope you had an informative session. And
Thank you,
anyone
ma'am.
has any doubts?
Thank you very much, ma'am.
And Dr.
Yes, the
Akankssha?
recording will be shared.
Yeah, Dr. Akankssha, hello.
Hello, yes, Dr. Ramya.
Yeah, first, thank you so much for
Thank
your
you, ma'am.
nice, lovely lecture. And secondly, because you're one of those lecturers that you will be in a subscription, no? Who are just
Yes.
getting the subscription. Can you just who are in going to take the subscription and have no experience with your subscription platform? So
Yes.
that will be the way that we are having. You will go through the MCQ and you will learn as by MCQ question, or no, you will
Yes.
give the lecture on then MCQ how it is working the platform.
See, here the platform, what we do is we teach you with the basis of MCQs, like we take up a question and then we explain you all the topics which are according to that. Okay.
Okay, in the same pathway that today in 1 hour you have done it.
Yes, kind of the same.
Okay, that
And
will be
in the like when we have a lot of time, there are multiple experts, not only me, but we have a very good team of all the expert doctors. They take up very nice sessions and very elaborative sessions. See, in the mock test, I had just have a 1 hour or 1 hour 10 minutes where I have to complete major chunk. If it is a daily classes, you can talk to our students who are taking up the daily class and they can be able to give you more details about it.
okay.
Or you can anytime connect with Dr. Munjal sir. He'll be the right person to help you out with what subscriptions you need and what time you have.
Okay. Thank you so much.
Yes. So anyone else would like to give any inputs, any suggestions that we could do for the next class? Anytime you're free.
Ma'am, is there any possible to discuss endocrine?
Okay, endocrine I have taken measure of the times, but okay, we
Yeah.
can do endocrine next time.
Ma'am, we want to learn about hematology.
Hematology, Dr. Munjal sir. He's the perfect
Yeah.
person.
Yeah.
Basics about pediatrics.
Pediatrics, okay, fine. We will learn about pediatrics. I'll also talk to Dr. Aarti. Dr. Aarti is our pediatric expert. I'll ask her to take one good session about pediatrics.
Yeah, ma'am. Thank you.
Yes. Thank you so much, Dr. Ramya. I hope you're the host. Can you see that I've made you the host?
Yeah.
Okay. Thank you so much, ma'am. Please carry forward.
Thank you, ma'am. It was a good lecture today.
Thank you. Thank you,
Welcome.
students. Bye-bye.
Thank you, ma'am. Thank you so much.
Thank you. Study well.
Yeah.
So, hello guys, all are active or want a
Good
coffee break?
afternoon, ma'am.
Yeah.
No, we are active, ma'am.
We are
You're
here.
active?
Yes, ma'am.
Okay. So, we'll continue last. I think we have like break that some 11th question, right? This was the last time which we were doing. So, we were talking about the preeclampsia, HELP, and hypertension, chronic hypertension with superimposed preeclampsia. So that we have finished the discussion. You are open to ask any doubts about that because it's very important. Can we proceed to the next question or is it okay?
Yes, ma'am, we can proceed.
We'll proceed,
Okay.
ma'am.
Okay, so coming to the next question. Mifra, you can go.
A woman with one previous LSCS presents in labor. Operative note shows classical uterine incision or contraction. Sorry. Shows a classical uterine incision. Best mode of delivery, trial of labor, induction with oxytocin, elective repeat cesarean section, vacuum assisted delivery.
So what do you mean by
I would like to know the POF this.
Okay. Maybe LCB was 5 years. Last child age is 5 years ago. Now period of gestation is term 30.
Then what was the indication of previous Caesar? It's important.
Breach.
So now she can deliver normally.
Trial of labor.
Trial of labor, but I need to know the weight of this time baby.
Okay. Scan is showing everything fine, no comorbidities. Baby weight is absolutely less than 3 kgs.
So we can go for trial
I
of
will
labor,
go
ma'am.
with trial of labor, ma'am. VBAC.
Yeah.
Okay. Any other opinion?
Even
Ma'am,
though
if previous
the
breech
elective
cesarean and no any short pelvis and no repeat indication, so I'm also with trial of labor.
Okay, fine.
even the
Any
scar of
different opinion,
the
please let me know for why. Same
ma'am,
opinion, it's okay. Abhi, tell.
I would go for C-section again because the scar of the previous section might be a problem for trial of labor.
Why do you think the
And
previous
only there
section
is
will be a problem?
one C-section, right?
Yeah.
So
See, what is classical uterine incision?
Yes.
Yeah, no one is
It's a
concentrating on this
it's a
classical.
vertical incision of the uterus.
So
Oh
usually,
yes. Oh
ah,
yes.
why you people are so like you are tuned to this answer? See, this is lower segment cesarean section where the incision is given in the lower segment transverse incision. So one LSCS. Then that is next delivery she should come with. She can go for trial of labor and that is known as TOLAC, trial of labor after cesarean. And if she delivers vaginally, that is known as VBAC. But if this cesarean is vertical, what makes the difference?
The upper segment we are putting in upper segment is strongly contracting
Very good.
during the delivery.
So always
there is a chance of rupture.
Even
So we have to
not
go for
even the
elective
patient should not be in labor. Even the patient at 36 weeks, there is a possibility of rupture. See, let me tell you what is the difference between this classical uterine incision and lower segment uterine incision. Here you are giving incision on the upper segment where you have muscles. So when it heals, retract, contract. This scar will not be very healthy. Here we suture in two layers. In the upper segment, when you give vertical incision, we might require 3 to 4 layers of suture. And it is more prone for rupture even before labor. This one, at labor, as you people are very perfect, if the last childbirth more than 3 years, non-recurrent indication for LSCS like breech, fetal distress, they have high success rate. Present condition like now, no comorbidities, where scan is showing adequate fetal weight, no macrosomia, adequate AFI, that is an indication for TOLAC. But if there is classical incision, there is no ever thought. Directly go for a repeat C-section. If the same question I have given you, a patient 37-year-old who had multiple fibroids when she was young, underwent myomectomy and removed 6 fibroids, and in the operation notes it was mentioned that the uterine cavity was opened during the surgery. Now came for assessing the mode of delivery. What will you
Cesarean
give the
section.
options?
Cesarean section.
Ma'am,
So
cesarean
same,
section.
because cavity opened and you will be given an upper segment. So that's why usually we'll go with elective repeat cesarean section. Okay.
I'm so
If
sorry,
it
ma'am.
is the same question I'm telling, a woman came with 2 previous LSCS.
This time also LSCS.
So 1 CS VBAC is okay. 2 LSCS is not
Cesarean.
VBAC.
LSCS.
Okay. Maybe you got confused with previous 1 LSCS, but no, because we can call all like cesarean delivery. Lower segment cesarean should not be called. Maybe previous, the question should be like this. Woman with previous 1 CS, presence in labor, operative note shows classical uterine incision in the previous delivery. Now, what is the mode? So it would be
cesarean.
Elective repeat cesarean section. And note one thing, nowadays no one is going to give classical incision because it's absolute. Only like if there is cervical cancer or if there is placenta accreta previa, where if you give incision on the lower segment, there only you go with classical uterine incision. Otherwise, classical uterine incision is not given nowadays. Always it's a lower segment cesarean section. Am I clear?
Ma'am, one thing, I'm sorry.
Yes, ma'am.
I'm sorry. Can you please tell me what the classical uterine incision, it's vertical and the other one is horizontal?
Yes. And this classical uterine section is vertical. I'm sorry. Classical cesarean section is vertical and it is put in the upper segment. So when I draw, this is the thing. This is the upper segment. So this is classical uterine incision and this incision will be this one. So in the lower segment there are no muscles. While healing it heal properly, and this is the, like when pregnancy goes on progresses, the upper segment distance, right? So their chance of rupture in lower segment CS is very less. Only in labor, LSCS scar will rupture. But if the scar is classical uterine incision, there is a possibility of rupture of uterus at 36 weeks. That's why if everything is fine, we'll go with a elective cesarean section at 36 to 37 weeks as per the indication. If patient is good, scar is good, no pain, you can wait till 37. Now, if patient is complaining of pain in the upper segment, then we'll go with delivery at 36 weeks itself. Am I clear?
Oh, yes, ma'am. Thank you.
Yes, ma'am.
Ma'am, if the lower uterine segment incision and the second is also breach, then also it will be LSCS, no ma'am?
I'm sorry.
Uh,
Yeah.
thinking-
If it is breach, yeah. Previous years in breach, she comes with breach and she wants
Again.
VBAC. Yeah, we usually VBAC will be given only if there are no comorbidities, last scan showing cephalic presentation, adequate weight, adequate A5 with no CPD, no placenta previa. There should not be any obstetric indication for LSCS. What are the obstetric indication for LSCS are like CPD, contracted pelvis, or like breach. Am I clear?
Yes, ma'am.
If there are no obstetric indication for LSCS, then only we go for a VBAC. To give VBAC, we have scores. Like we have many scoring system where the previous mode of delivery matters, what is the age gap between the two kids matter, what is the last, like what is the present baby weight. According to that, they give a score. The score, if it is more than 6 or 7, high successful rate for vaginal breech, VBAC, vaginal delivery after cesarean. If the score is less, still you can tell the patient the score is less, we will induce, but the possibility of failure is high. Is it okay for you? If the patient agrees, you can go with that. Now, coming to induction of labor. Would you give prostaglandins to a patient who had one previous years?
No, ma'am. No.
So, what you will give then? Patient is telling, I want only vaginal delivery. The patient is 39 weeks or 40 weeks. Patient still not in labor. Then what you will deliver? How you will deliver?
By induction with syntocinon, but not pessaries.
Okay. Only syntocin, anything else?
Foley, ma'am. Foley catheter.
Foley catheter.
Foley's, yes, yes.
You can insert Foley into the cervix. That is the mechanical induction. Second thing is syntocin with care. Okay. So we'll discuss more in the routine regular class. So this is like all previous years. It's a silent vertical incision or classical incision is an absolute contraindication to VBAC. Okay. Next question, Rabia.
Yes, ma'am. 26 years old primary gravida, 38 week, present with PROM for 20 hours. She is febrile, GB status.
She's ephemeral.
She's febrile, GBS status unknown. Glucose, what is stain for GBS here?
Group B streptococcus.
Okay. ये repeat rupture membrane के साथ आइए. Await spontaneous labor, start broad spectrum antibiotic, start GBS prophylaxis, cesarean section. Ma'am, start with broad spectrum antibiotic for prevention.
Any other opinion? You have told answer B, Rabia. Am I correct?
Yes,
Yes,
ma'am.
ma'am. I'm with B.
Anyone? Any other opinion?
I'm also go with B, ma'am. Broad spectrum
Okay, Abhi?
antibiotics.
Mifra?
20 hours, no, wait.
Why not go for C-section as soon as possible?
Next step.
So, Abhi, will the C-section avoid GBS to the baby?
We will go
Okay.
with the start broad spectrum antibiotic.
Okay. So, see, here, you should always know what is GBS. So GBS is a group B streptococcus organism which will have detrimental effect in the fetus. The fetus may go into pneumonia, like it has cerebral sepsis mainly. Okay, so that's why GBS is very important in a pregnant lady. Okay, especially when there is rupture of membrane. Rupture of membrane can be PPROM, PROM. What is the difference?
Premature.
Premature pre-labor, ma'am.
Premature and preterm.
So PROM. So let me tell you. So PROM is term, more than 37 weeks. Less than 37 weeks, that is known as PPROM. Okay. So preterm babies are more prone for this GBS. So PPROM, irrespective of the time, how much time she was in rupture of membranes, PPROM, immediately you should start with GBS prophylaxis, not broad spectrum prophylaxis. Broad spectrum prophylaxis include like all big drugs. GBS prophylaxis is simple. It is benzathine penicillin. Sorry, benzyl penicillin, not benzathine, benzyl penicillin. So it's penicillin. Okay. If they are allergic, mild allergic to penicillin, they can go with ceftriaxone. If they are severe allergic to penicillin and cephalosporins, then you have to go with vancomycin. Am I clear?
Yes, ma'am.
So usually for GBS prophylaxis, what we do is we give medications to the mother so that we prevent infection to the baby. So whom you give? Usually if it is the first pregnancy, we will check a vaginal swab 35 to 37 weeks. And if the swab is GBS positive, you have to give GBS prophylaxis. Second thing, previous baby has been affected with GBS. Then this pregnancy, you should take the swab. If the patient came in labor, you couldn't take, then you have to give, irrespective of the swab report, you have to give GBS prophylaxis. Third thing, patient had UTI. When culture was done, it was GBS in the urine culture. That means there is GBS somewhere in her body. Those patients also you should give GBS prophylaxis. And certain risk factors. As I was telling, what are the risk factors? Rupture of membranes. If it is preterm, all preterm rupture of membranes, you should give GBS prophylaxis. If it is term, then more than 18 hours. Here, what is the, how many hours happen? 20 hours. So, if it is more than 18 hours, term patient, then you should give GBS prophylaxis. If it is less than 37 weeks, immediate rupture, immediately you should go with the prophylaxis. If at all patient is having intrapartum high grade fever, that is also indication for starting GBS prophylaxis. Okay, elective CS, if your patient is going, if this same case I am telling you, G2P1L1 previous LSCS at 38 weeks with intact membrane, should we go with prophylaxis? No, because still the membranes are intact and we are going for elective CS. If you are going for elective CS, then there is no need of GBS prophylaxis. If there is rupture of membranes, then only we give that. The treatment of choice is penicillin G or ampicillin. If they are resistant, ceftriaxone. If they are highly resistant, like if they are anaphylaxis, then you will go with vancomycin. Okay. So this prophylaxis is given only when the patient is in labor, not in the antenatal period. This is mainly given to avoid early onset of neonatal sepsis. Am I clear?
Yes, ma'am.
So the same concept, they can give multiple questions. If I told you there is a primigravida who is at 35 weeks presented with rupture of membranes, She is afebrile. GBS status unknown. Next step. What to do?
Benzel
Start
penicillin, ma'am.
antibiotic prophylaxis.
So yeah, give intrapartum GBS prophylaxis because this is preterm
Preterm.
rupture of membrane. Even if the GBS status is unknown, we have to give. The same scenario, primary gravida, 38 weeks, is in labor with GBS status showing positive. Then what?
Then give prophylaxis during
Intrapartum.
intrapartum
Yes,
during
because
labor can transmit to the baby.
yeah, because anytime in labor, if she has to deliver, she has to rupture the membranes, right? So if the GBS is positive, then you have to give. Am I clear?
Yes, ma'am.
So you have to note down these indications, dear. Once again, I am telling the indications. Indications are, one thing is GBS positive in the pregnancy when you take swab, previous baby affected with GBS. Third one, any preterm rupture of membranes. Fourth one, term rupture but beyond 18 hours. If she is having fever, all these things are indications for GBS or GBS bacteria. Okay, so these patients should be given. Next, they'll even ask what antibiotic will you give? Piyush, what antibiotic will you give?
Penicillin. Benzyl penicillin.
Penicillin G. Okay. If she's allergic to penicillin,
Then we can give ceftriaxone, cephalosporin,
if she is allergic to ceftriaxone, vancomycin.
vancomycin.
So these are the probable questions that they might ask you for GBS. Okay, it's not broad spectrum, dear. It's GBS prophylaxis. Okay.
Okay,
Next
ma'am.
question, Piyush.
During vaginal delivery, head is delivered, but shoulders are stuck. What should not be done initially? Option A, make Robert's manual. Option B, suprapubic pressure. Option C, fundal pressure. And option D, episiotomy. Ma'am, it is a case of shoulder dystocia.
Yes, very good.
So my answer is should be not done initially. So answer is C, fundal pressure.
Very good. So when you do macrobots maneuver, legs onto tummy, there will be more space in the pelvis. When you give suprapubic pressure, we are displacing the shoulder to anteroposterior diameter
Anteroposterior
so
diameter.
that the wide diameter, the shoulder will come out. Episiotomy is done to increase the space. Bring the patient to the edge of the table also can be done, but never ever give fundal pressure. The fundal pressure will cause more and more,
Uterine rupture.
not rupture, but this impingement of the shoulder. You are again trying to impinge the shoulder onto the pelvis. That's why fundal pressure is avoided. Further impingement, so further difficulty. Okay, so it should come away from the impingement. Then, because see, whatever fundal pressure we give, it's not so harsh that it will cause rupture. Maybe rupture is there, but mostly why you tell no, because further shoulder impingement onto pelvis will be there and it worsens the situation. That's why we tell not to give fundal pressure. Am I clear?
Yes, ma'am.
Yes, ma'am.
So it worsens the impaction. So that's why DHA loves what not to do. Please, I'm telling you 100 times, read the question properly. What not to do, what they're exactly asking, or what is the first initial step to be done. So you know the concept, but you should be alert in the exam. That makes you a step ahead from the others. Okay? So 15th question. Read. Mifra, One of you can take.
A 32-year-old woman has a asymptomatic 5 centimeter simple ovarian cyst detected incidentally. Best management, laparoscopic, repeat ultrasound after 6 months, CA 125, start OCP. 5 centimeter, asymptomatic.
Incidentally.
Repeat ultrasound after 6 months.
Any other opinion?
CA 125.
CA 125, just in case.
Can we start with OCP?
Ma'am, they ask best management. So I would go with laparoscopy.
Very good. All the options everyone told. So it will be very nice for me to explain. Okay, see dear, this is 32-year-old. So what does it indicate? She is in reproductive age group. She is not menopause. Okay. Second thing, asymptomatic incidentally. So she doesn't have any symptoms. This was just she went and she was found as ovarian cyst, that is simple ovarian cyst of 5 centimeter. Okay. If the same question, if the parameters has been 4.5 centimeter, it is different. Okay. If it is 5 or above 5 centimeters, that is different. So if it is 4.5 centimeter, that means it is less than 5 centimeter. You need not to do anything, not even ultrasound. You can just tell this is a follicular cyst, not to worry. If you are so worried, you can repeat an ultrasound and see. Okay. Here, more than 5 centimeter, you have to be evaluating if she is high risk. Like she had a previous history of ovarian cyst, or any family history of malignancy, or any family history of breast cancer, or any family history of colon cancer. In that situations, you can go with CA 125. Here, you can reassure her because it's a simple ovarian cyst. So best management would be repeat an ultrasound after 5 months. Not laparoscopy because she's found incidentally, right? So this is not symptomatic. If a patient comes to you, pain abdomen, vomiting, nausea, even if the cyst size is 4.5 centimeter, but if the patient is having severe pain, nausea, vomiting, that means torsion. So then you have to go with laparoscopy. Okay. Here, because there is no symptoms, why not CA 125? If you ask me why not CA 125, my explanation would be because it is written it's a simple ovarian cyst. Please, will you mute Asya? Okay. So it has been written that it's a simple ovarian cyst. So if it is simple, then there is no need for going into CA 125. So the best option would be repeat an ultrasound after 6 months.
If the cyst size was around 8 centimeter or 10 centimeter,
then you should go with CA 125 because that is a high risk. More than 7 centimeters, you have to treat it. Then you have to assess CA 125 because big cyst, rule out malignancy, then go for laparoscopic treatment. More than 7 centimeter, even if they are asymptomatic, go for surgical management because that might lead to torsion in future. OC pills. Previously, they used to tell for simple ovarian cyst, OC pills are good. But evidence-based medicine gives very low, like 4, maybe 4 they're telling. So there is no point in giving OC pills because if you give that, it will further cause all these thrombotic side effects and headache, vomiting and all. So OC pills nowadays we are not giving for any ovarian cyst. If the question was like this, asymptomatic 8 centimeter ovarian cyst with normal tumor markers, then the answer would be laparoscopy. Asymptomatic 8 centimeter, simple ovarian cyst, detected incidentally. What is the next step in the management? CA125. Next step, not the best management. See, here the words are different. Next step in evaluation, CA125. If it is more than 7 centimeter, you can also go with MRI pelvis to assess the characteristics of the ovarian cyst. So, here best management would be reassurance, repeat ultrasound after 6 months to 12 months. And the same is different for postmenopausal lady. If this is 55-year-old who came with the same asymptomatic 5 centimeter, then you will go with CA125 because they are more prone for malignancy. So the best management would be ruling out the malignancy. If CA125 is normal, then you can ask her to come after 6 months. Patient asymptomatic 6 months. Again, if the cyst is same 5 centimeter or if the cyst has increased to 7 centimeter, this is for surgery. If this is for 6 centimeters same, you can explain. You can go either for surgery to rule out malignancy or you can again wait and watch 6 months later. Again, you have to repeat a scan. Am I clear?
Yes, ma'am, but in the same question, if it says symptomatic 5 centimeter simple ovarian cyst, patient, subfertile patient with a symptomatic 5 centimeter simple ovarian cyst, then what would be the best management, ma'am?
See, if they have included subfertility in the question, then any fertility issue with more than 4 centimeters of ovarian cyst has to be treated. So then that could be laparoscopy. If subfertility is there and she is trying for pregnancy, she is not becoming pregnancy, because that is a symptom, right? She is not becoming a pregnancy is a symptom. You cannot tell asymptomatic then. Fertility issue is there. And on evaluation, she was found to be ovarian cyst. And usually that ovarian cyst would be endometriotic because simple ovarian cyst will not hamper pregnancy. Only endometriotic cyst will hamper pregnancy. So if it is endometriotic cyst of more than 4 centimeter size, yes, you have to go with laparoscopic removal of the ovarian cyst. And the same scenario, they can give like a 14-year-old adolescent lady, adolescent girl. So that is very significant. Adolescent less than 3 centimeter, not to do anything. But if it is 5 centimeters, she has to get evaluated with all the tumor markers. And if everything is normal, patient doesn't want any surgery, you have to call her back after 3 months, not 6 to 12 months, because younger patients. So we will call in 3 months. So all these are the in and out of an ovarian cyst. They can give you adolescence. How you remember? I'll show you. So if it is adolescent, more than 3 centimeter require further follow-up. If it is reproductive age group, more than 5 centimeter, further follow-up. This is 3-month follow-up. This is 6 to 12-month follow-up. Postmenopausal lady, 5 centimeter, CA125. And if it is abnormal, CT scan and further surgery. Here, we'll just check into the size. When in reproductive age group, you will go for surgeries more than 7 centimeter to 8 centimeter. Evaluate with other tumor markers and then go for surgery because they are more prone for torsion of the ovary. If this at adolescent, usually they'll have small hemorrhagic cyst. So for hemorrhagic cyst and all, not to worry. You can follow up after 6 weeks. Okay? Am I clear?
Yes, ma'am.
Yes, ma'am.
Asymptomatic means she doesn't have any symptom, including like pain, subfertility, no vomiting. Asymptomatic is asymptomatic. If in this, if anything is added, then that will be different. Okay? You can solve questions of these things, and then if you have any doubt, you can post it in the group. So simples is less than 5 centimeter, reassurance. Simples is 5 to 7 centimeter. Observe, follow up 6 to 12 months if the patient is asymptomatic. See, at any moment, if the patient is symptomatic, you can treat. You can go with tumor markers. You can go with laparoscopy. Okay?
Ma'am.
So, Shahila, read the question.
Yeah, woman with IUCD presents with PID, ma'am, pelvic inflammatory disease. Best statement. IUCD must be removed immediately. IUCD causes PID. IUCD can be retained if responding to antibiotics. Surgery is mandatory.
So they'll give a big scenario. The patient is para 2, live 2, who delivered, and after delivery he has been inserted IUCD. Now presented with, here I gave directly PID. They'll give fever, abnormal white discharge, cervical excitation, cervical tenderness positive. Now the best statement should be, what is your best statement? What you will do, Shahila?
I will go
E.
with A,
E.
ma'am. IUCD must be removed immediately.
Okay. Any other opinion, dear?
IUCD can be retained if she is responding to
Can be
antibiotics.
retained.
Same,
Yeah.
ma'am. IUCD can be retained if
Okay.
responding to antibiotics.
Yeah. So of these three options, yeah, IUCD causes PID, I do agree. But here, what can be done for the patient so that it's a best management? So there is no need of removal of IUCD once you are diagnosing that patient with PID. You can give antibiotic. After giving 3 days of antibiotic, if the patient is well responding, fever has subsided, cervical excitation has come down, if she has been responding, you can retain the IUCD.
Okay, ma'am.
If after 3 days also the patient have persistent symptoms like still discharge, still fever persistent, then step up to IV antibiotics, admit the patient, remove the IUCD.
Yeah.
If the same case, IUCD presents with fever, severe pain abdomen on USG, there is a left adnexal mass, 5 into 5 centimeter possibility of tubo-ovarian abscess, what's your management?
Abscess must be
The
drained.
abscess removed.
So then if it is TO abscess, you can give IV antibiotic because it's only 5 centimeter. It depends whether she's sepsis. She's in sepsis, then you have to go laparoscopically remove the septic foci. The patient just came with pain, TO abscess, no sepsis features. You can give IV antibiotics or oral antibiotics. Do a repeat scan. Am I clear?
Okay, ma'am.
TO abscess as such, direct surgery, no. TO abscess with features of sepsis, yes, you have to go with the surgery because you have to remove the septic foci. If TO abscess alone, maybe she might respond to the antibiotic. Okay?
Okay, ma'am.
And regarding IUCD, you can keep it, no problem. If she is responding, you can keep it. So here the answer could be keep the IUCD, give
Retained.
oral
Retained.
antibiotic. If no response after 48 to 72 hours, shift to IV antibiotics and remove the IUCD. Okay?
Okay, ma'am. Yeah.
Okay. So next, Kavita or Sandhya, Akbar, Arun, anyone? They are silent people? Okay. Then,
26.
who is this Xiaomi? Nice. Yeah, read this question, Lee.
A 26-year-old woman with PCOS, BMI 34, infertility for 2 years, best initial management. Letrozole, Clomiphene, C weight reduction, degonadotropins. I think it should be weight reduction.
So the first step always is lifestyle modification before ovulation reduction. I agree with you, Noshin. If the question has been in this way, like 35-year-old, 36-year-old with PCOS, same BMI, then there should be weight reduction along with that, any of the ovulation reduction also. Because beyond 35 years, we should be very
elderly pregnancy.
yeah. So beyond, we should be aggressive in treating the patient. So if beyond 35 years, you should, along with weight reduction, you should always go with ovulation induction drugs like Letrose. Letrose is the best drug for PCOS for ovulation induction, followed by, if there is no response to Letrose for 3 to 6 cycles, then we go with gonadotropins. Am I clear?
Yes.
Not in this patient if the question has been changed. Okay. Here, lifestyle modification is a thing. Next question. Any one of you can take? Please be active in the class, dear. If you people are interactive
60-year-old
only,
lady.
class is good.
60 years old lady with postmenopausal bleeding, ET3 persistent bleeding. What is your next step? Endometrium thickness is 3 and persistent bleeding. A,
Yeah.
reassurance. B, repeat ultrasound. C, hysteroscopy and endometrial biopsy. D, progestin. The answer should be C.
See.
Any other opinion? Because endometrial thickness is only 3 millimeter, less than 4 millimeter.
But she is persistently bleeding.
Very good.
This
So
is
that is the
symptomatic
thing.
and persistent bleeding in menopause.
So persistent bleeding, recurrent bleeding, these all things clinches, something is there to evaluate. Even if the endometrial thickness is normal, you have to evaluate her by either hysteroscopy and go with either only hysteroscopy, because already endometrium thickness is very less, right? So biopsy you will not get anything. So you can do hysteroscopy. If required, you can take biopsy accordingly. The advantage of hysteroscopy is you can see and you can treat. You can see where there is abnormality, and then you can treat that by taking, if there is a polyp, you can do simultaneously polypectomy. Am I clear? So it's USG, it's a trap. You should always think persistent or recurrent bleeding, you should go with hysteroscopy. Okay? If they have given hysteroscopy in one option and endometrial in the other option, endometrial biopsy in the other option, choose hysteroscopy. Okay? No
Okay,
blind
ma'am.
endometrial biopsy when the thickness is less and when there is persistent bleeding. Blind OPD biopsy is done when the thickness is more than 5 millimeter. Okay?
Ma'am, I didn't get you, when hysteroscopy and endometrial biopsy are two different options, what should we choose?
If the question is the same, we should choose hysteroscopy only, because we don't know from where it is bleeding. So you have to examine whole uterus, then only we can know where it is bleeding. So hysteroscopy would be preferred. Okay?
Okay,
If
ma'am.
the question is telling the endometrium is 10 millimeter, more than 5 millimeter, the next step would be, in that situation, they give only endometrial biopsy sometimes. Then you can choose endometrial biopsy. But if they give hysteroscopy with endometrial biopsy, that would be the best option. But if endometrium is thickened, you can even choose endometrial biopsy as a best option. Now you got me?
Yes, ma'am, got it.
Okay. Can we go to the next question?
Sure, ma'am.
Yeah. So Nahid, Joanna, Rajesh not there this class? Anyone here? Just take.
CA125 is not useful in A.
Huh?
Monitoring treatment, screening general population, C. Recurrence detection, D. Prognosis.
Yeah.
It's not useful for screening general population.
Yes, correct. So what is the CA125?
It's a common tumor marker.
Tumor marker.
So it's cancer antigen 125. It is a tumor marker. It is usually elevated in epithelial ovarian cell cancers. Okay. So you can use these as monitoring the treatment. If I see a endometrium case is there, we have done surgical staging laparotomy. So we have, after that, we usually call them by checking CA125 whether that is recurrence or not. Okay. For recurrence detection, also to prognosis, like I was telling you, right? If there is a postmenopausal lady who has an ovarian cyst where the CA125 is 2000, that means it is highly indicative of some malignancy. You have to rule out by doing a CT scan. What is the problem? So it also tells the prognosis, but you cannot screen the general population. It's never, because it is elevated in endometriosis, in ovarian endometrial cancer, pregnancy, even in non-gynec situations like lymphoma, liver cirrhosis, pneumonia, TB, CKD. In those situations also, the CA125 is elevated. So it is never a screening test for a general population. If there is an ovarian cyst, then you can use it as a tumor marker to assess the prognosis or whatever it is. Am I clear? Hello?
Yes, ma'am.
Yes, ma'am, please continue.
Okay. So next question would be?
Uh, 26-year-old lady presented to emergency with acute abdomen. During surgery, ovary appears black and necrotic. Next step is option A, oophorectomy, D, torsion and preserve ovary, option C, biopsy, and option D, close abdomen. It's look like ovarian torsion, ma'am.
Yes, that's ovarian torsion.
So diagnose. So next step is detorsion and preserved ovary. As woman is 26-year-old, we cannot do. We avoid oophorectomy.
Yeah, so that would be the proper answer. Like, because the patient is a young lady, what we can do is we can detort. After detorsion, you can wait 15 to 20 minutes. Again, look into the ovary whether it has retained its vascularity. Okay, if it's retained its vascularity, so always you can go with preserving the ovary. Okay, but if you feel that is infected, black, and you can see signs of peritonitis and all those things, then you have to remove the ovary. Okay, because for every case of torsion, we evaluate the patient with CBC, and like we look into counts and all, right? So if the counts are elevated, already we don't know since how long this torsion has been, and already sepsis is in, then there is no point in preserving. And try to go with ovarian cystectomy rather than oophorectomy. Oophorectomy means completely removing the ovary. So one side of the ovary is removed, there is high possibility that her fertility concerns will be, like in future, it will be compromised. So it's always better to go with detorsion and preserve the ovary. If the option doesn't have this, you can then choose oophorectomy SOS.
Doesn't
Any
the
doubts here?
necrotic tissue it indicates that the loss of vascularity has been too long?
See, that is what previous guidelines used to tell is when it's black necrosis and all, they used to tell you just go with oophorectomy. But now recent guidelines are telling that ovary has very good, like like liver, how it rejuvenates and it comes back to normal once alcohol intake is stopped. In the same way, they are telling you can detort, keep for some time, and the vascularity will be usually retained for the ovary because it's a direct artery from aorta, right? If after 15 minutes also still it's black and you feel that the tissue is not vitally, like vitality is lost, then you can go with oophorectomy. That is the surgeon's decision. Always laparoscopy is preferred. Always we should try to preserve the ovary. These are the two things that you should keep in mind. Okay?
Okay, ma'am.
As we were discussing, if the counts are more and already sepsis has been in, then you have to remove it. Okay? Oh, sorry. I think this one last time we have discussed this question.
Recording in progress.
Okay, you can. I'll skip this thing here. This one already last time we discussed, I think. Next question. Abhi or Rabia or Mifra, whoever wants here.
Primary gravida at 32 weeks pregnancy, decreased fetal movement, NST, non-stress test is non-reactive, BPP score 8/10. Next steps. Immediate delivery, repeat NST, reassure and discharge, emergency cesarean. And what is BPP?
It's biophysical profile. Anyone know what is this? Abhi?
Amniotic fluid index and non-stress test, ma'am.
Yeah, that are parts of BPP. There are 5 parts in BPP. So biophysical profile is the assessing how much like baby is good and all. So in the biophysical profile, we have one thing is fetal movement. Next thing is fetal tone. And third thing is fetal breathing. Fourth thing is A5. Fifth thing is NST. So it has 5 components dear. Each component has been given a score of 2. So 5 into 2, 10. If the score, BPP score is 4, 6 or less than 6, that is baby is compromised. There is a chance of fetal demise or there is a chance that baby might have acidosis and all those things. NST means non-stress test. Non-stress test have 4 components. One is you check the baseline heart rate, you check the beat-to-beat variability, you check whether there are accelerations or not, and there should not be any decelerations. So it's a simple funda like if you run, your heartbeat increases. In the same way, if the baby inside a mother's womb move, the heartbeat will increase. That is known as acceleration. That is a reactive finding. Okay. So when the NST is non-reactive means that is not a good finding. But the BPP score is 8/10. That means this is reassuring. BPP score is good. So the next step would be
repeat NST.
Repeat NST.
You can repeat NST or you can reassure and discharge because she is only 32 weeks here. NST is non-stress test which becomes mature after 32 weeks because for it to mature, sympathetic and parasympathetic system of the baby should be mature enough. So usually what they tell at 28 to 32 weeks, we won't suggest NST at this preterm age because their parasympathetic and sympathetic are not well mature. If at all you did that and it is non-reactive, you wanted to make sure that everything is fine, you can go with BPP. If that is normal, you can reassure and discharge. If the same thing comes at 38-week pregnancy, decreased fetal moments, CTG is non-reactive or NST is non-reactive, BPP is 8/10, then you can repeat NST. What is CTG and what is NST?
CTG, isn't it fetal cardiac?
Cardiac topography.
So cardiotocography is the same thing, but when the patient is having contractions, we put two probes. One probe is to monitor contraction, the other probe is to monitor the heartbeat. Non-stress test is just only we are keeping the fetal heart rate and check the movements. Okay? So when the patient is in labor, you keep CTG. When the patient is not in labor, you give NST. Am I clear?
Yes, ma'am.
Yes,
Here,
ma'am.
because she is 32 weeks, the CTG or the NST, which is non-reactive, is not so significant. Accompanying with the BPP score being normal, you can reassure and discharge. If the same question tells that the pregnancy is term 38 weeks with a non-reactive CTG, even if the BPP score is good, you should not discharge her. You should repeat a CTG. Make sure that the CTG is reactive.
Ma'am, if the same question say the BPP score is 5, then what to do?
5 will not come here. It should be even because 4, okay. 4/10. That means there is some abnormality. You have to admit the patient. You have to evaluate what is wrong with the baby.
Okay.
4/10.
Up to 6 is normal. We
Yeah.
can
4/10. This is BPP, right? The next good and effective thing to monitor baby is Dopplers. What are Dopplers? So it's umbilical cord which is supplying from the placenta to the baby, right?
It shows
So you
vascular.
can check the Doppler of the umbilical vessels whether the blood flow to the baby has been compromised. If the blood flow to the baby is compromised, there is absent flow to the umbilical artery or reversal of flow to the umbilical artery, you have to deliver by C-section. Okay.
Okay, ma'am.
So, in fetal monitoring, let me tell you, in fetal monitoring, there are few things like one is NST or CTG. Second thing is BPP. Third thing is antenatal Dopplers. Okay? NST, I told you, you check the baseline fetal heart rate, which is 110 to 160. And beat to beat variability. Every beat, it should not be like flat line. It should be like this. And these are accelerations. I think my first class was this, right? Accelerations and decelerations. So accelerations is 15 beats rise in the heartbeat lasting for more than 15 seconds. That means it is acceleration. So if the acceleration is there, that is reactive CTG. And decelerations should not be there. So this is reactive one. It is usually seen after 32 weeks, CTG. BPP has 5 components: fetal movement, fetal tone, fetal breathing, and CTG or NST with the AFI. AFI is amniotic fluid index. Nowadays, there is modified BPP where you won't check all these things, only this NST and AFP will be taken into consideration. Dopplers are next step in evaluating. You check umbilical artery Doppler, you check middle cerebral artery Doppler. So if these are normal, you can wait. You can teach her how to check fetal moments. You can check if these are abnormal, then treat accordingly. These are antenatal fetal surveillance tools. Okay? Any doubts?
Okay, ma'am.
So, BPP more than 8 is reassuring. Scary NST is a trap. But if good BPP is there, you can wait if that is a preterm. If good BPP, if it is a term baby, then again you have to go with the NST, repeat NST again. Okay? Already we did this question already. Shalia? Shahlias. Anyone can take.
Yes,
Piyush,
ma'am.
anyone can take.
With women
Anyone
with
can.
one previous LSCS, Bishop score of 3, which is contraindicated. Follis catheter, oxytocin, prostaglandin E2, and artificial rupture of membranes.
So here Bishop score is very low. So we have to induce.
Yes,
So
ma'am.
what is the one which we contraindicate in a patient with one CS?
C.
Yes, very good. Because prostaglandins will cause rupture of the
Rupture of membranes.
So that's why it's contraindicated in VBAC.
VBAC,
Piyush,
yeah.
next question.
Progress.
Dichorionic diamniotic twins. Twin A
Oh.
vertex presentation. Twin B breech presentation at 37 weeks of pregnancy. Best mode of delivery. Option A, elective cesarean. Option B, vaginal delivery. Option C, external cephalic version. Option D, forceps delivery. Twin A vertex 37. So, dichorionic diamniotic twins. Whether it is a woman in labor or not.
Yeah, you can keep that the woman is in labor. Your question
It's a
number?
twin pregnancy, and we also consider the weight of both the baby.
Yeah, weight of both baby maybe 2.5, 2.3.
So we can try vaginal delivery.
Any other
external
options?
Catholic version?
And external
Ma'am, I will go
version
for
is not an option.
elective C-section. Elective
Forceps
TC.
delivery also not an option. We have elective or vaginal. As the first twin is cephalic, we can go for vaginal delivery as it's the best mode compared to elective.
I'll
Yeah,
also go
here
with
they ask the best
D.
mode. If first twin is cephalic, you can always go with vaginal delivery. Explain second twin, we will try to either deliver as a breech or we'll try to do internal podalic version where you keep your hand inside podalic version. You do the whatever external cephalic version cannot be done here because see, if you externally you change the twin B breech to cephalic, what will be the twin A happen? So in twins, no external cephalic version. If it is single, then breech, then you can give the option of external cephalic version if the patient is not in labor. But if twins, first one cephalic, directly go for vaginal delivery. Explain the chances of cesarean section for the second twin if something goes wrong. If the first twin is breech, then what? Piyush?
Cesarean section.
Directly cesarean. Because the interlocking of both the heads will happen. First breech. Breech will come. Head will be there. Head of the first baby and the head of the second baby will interlock. So, simple funda keep in mind. Twin A vertex, normal delivery. Twin A non-vertex position, directly C-section. Okay? Am I clear?
Ma'am.
Yes, ma'am.
Ask Piyush.
Hello.
Tell me.
Ma'am, in option, in place of vaginal delivery, if vacuum delivery option is given, then what the answer?
Why will you do vacuum for everyone? No.
And even
If
if it
there
is
is
cecally
indication for
pressed,
vacuum, see here, best mode of delivery is vaginal. Even you tell vacuum assisted delivery, forceps assisted delivery, because if there is any indication to go with assistance, then only we will assist, right? See, if there is maternal exhaustion where the mother couldn't push, or if there is fetal distress, or if there is any indication, then only you put vacuum and forceps. It's not like it's twin delivery, so we will help by vacuum. No. Here, if the question has been like the patient is in labor, twin A being vertex, she is in labor since 1 hour, there is no further progress, mother is distressed, she cannot push further, then vacuum. Same question. DCDA twins, mother is having heart disease, we have to cut short the second stage of labor, twin A vertex, twin B breach, then
cesarean section.
then
Elective cesarean, ma'am.
No. Why will you go with elective cesarean section? Cut short
Ma'am,
the second stage, forceps delivery. Cut short the second stage, forceps delivery can be done if everything is fine. If everything is fine, you can go with forceps delivery.
Okay, ma'am.
Cut short the second stage of labor, vacuum or forceps, always go with forceps, because vacuum, mother also has to strain. Actually, why you cut short second stage? When you give this pushing pressure, okay, all the vascularity, all the blood will come enter into the circulation. It will increase the overload. So to avoid that, we will cut short the second stage of labor. We will not allow that lady to push longer. We will try to ease the delivery by using forceps delivery. Vacuum, we will not give, because in vacuum also mother has to give some sort of pressure. So these are the questions how they can twist. If they're asking you heart disease, cut short second stage, then or if the patient is having severe preeclampsia, cut short the second stage, forceps delivery. If they're just telling maternal exhaustion, fetal distress, head is down below, you can go with vacuum assisted vaginal delivery. Otherwise, directly they can go with vaginal delivery. There should be an indication to apply vacuum or forceps. Am I clear?
Ma'am,
Piyush?
vacuum and
Yes, ma'am.
forceps, it should be fully dilated, no, ma'am, 10 centimeter. No?
That are prerequisites.
Ma'am,
Without
can you clear us today vacuum and forceps at plus or minus stations? We are very confused on it.
Okay, see, I'll tell you. There are prerequisites. Okay, what are prerequisites? Without these, you cannot give vacuum or forceps. So the prerequisites are: cervix should be fully dilated. 2, bladder should be empty. 3, vertex, the position of head. I already told you, I don't know in the mock or in the general section. So if this is the ischial spine, at the level of ischial spine, if the head comes, that is 0 position. So if the head is above 0, -1, -2, -3. So if the head is above 0 and the patient labor is stuck, directly go for LSCS. No vaginal, no forceps, no vacuum. If it is beyond +1, +2, +3, then only you go with vacuum or forceps. Okay. Vacuum versus forceps, which one to choose at what time? If the head vertex is at +1, completely rotated, that means usually occipito anterior means fully rotated head. If full rotation is there and then the head is not coming, then you can go with forceps. If rotation is incomplete, they mention baby is in occipital transverse at +2. What would be your option? Because when the rotation is incomplete, you cannot apply forceps. You can apply vacuum, which will cause descent of the head along with mild rotation. Am I clear?
Yes, ma'am.
In vacuum, the mother has to strain, vacuum will be done along with the contraction. Along with the contraction, you pull because mother pushes, uterus pushes. Along with this, you just try to ease the delivery. In forceps, irrespective of contraction, you apply. This is the head of the baby, right? You apply this spoon, you lock this spoon, you give good traction, pull it off. Okay? If they ask you with the forceps, the problem is it's good for the baby, but it's bad for the mother because when you pull the forceps, there will be perineal tear, extensive vaginal tears, cervical tear. So it's not so preferred. Vacuum delivery is good for mother because it doesn't harm anywhere in the pelvis. The bad thing with the vacuum is because the vacuum is applied onto the head, right? This is the head. The vacuum cup is applied over here. Because of the traction on the head, there may be caput or chignum. That is okay. But if the pull is extensive, there might be vessel tear, which will cause hematoma, subgaleal hematoma or whatever hematoma. So that is vacuum is always avoided. That's why vacuum is always avoided in preterm deliveries less than 34 weeks. Vacuum is avoided. Only forceps can be put. Okay. But in certain situation, if that is a face presentation, okay, if it is a face, if it is a after coming head breach, that means breach has come but head is stuck. So after coming head. So in these situations, vacuum cannot be put. Only forceps. How can we put a vacuum onto the face? We cannot put, right? After coming head, can you put vacuum? No. Only forceps can be put. Got it?
Yes, ma'am. Thank you.
For forceps, usually from here, +1, +2, low forceps, +3 above, outlet forceps. Nowadays, previously they used to have mid-cavity forceps, which are very big. And they also had like the key forceps name are curve forceps. They can rotate the head. Position can be changed. Okay. Like if there is occipital transverse, then it will convert into occipital anterior. Okay. So the rotational forceps are banned nowadays because they are causing extensive injury onto the like Kielan's forceps. Example is Kielan forceps, Neville-Brand forceps, Simpson's forceps. These are mainly done when the patient is having occipital posterior, occipital transverse, then it will correct to occipital anterior, then take. Outlet forceps, it can be applied only if the position of the head is occipital anterior. So now what you understood, you should know the position of the head. You should know whether the presentation is cephalic or not. You should know whether the pelvis is adequate. You should know whether the cervix is fully dilated. So these are all the prerequisites. With prerequisites only, you will decide whether to put a forceps or whether to put a vacuum. Obviously, you have complications, maternal and fetal. Just remember, forceps, maternal complications are more. Vacuum, fetal complications are more. Am I clear?
Yes, ma'am.
Just you prepare a table between vacuum forceps. Don't get confused. There are
Actually,
no mid cavity big forceps nowadays. It's absolute. They won't give you question, but you should have a knowledge upon it. Like what are rotational forceps? Keelan, Simpsons, Neville Brownie. What does they do? If the baby head is occipito posterior or occipito transverse, these forceps will rotate the head and then bring out. Okay, that much is enough for your level. This much is enough for your.
Is this,
Ma'am,
this much
enough.
detail necessary for the GP exam? Because I haven't done OBGYN after graduation. So
See, the thing is, they will ask. I think there is one question in Munjal Sir's thing, whether vacuum or forceps. I think they'll ask, yeah, because this is a basic. They can ask you what is the because see, GP, you are in the labor room. You are a labor room GP. You should know basic idea. What is vacuum? What is forceps? When to apply forceps? When to apply vacuum? Right? So these are basics. Whatever I told are basics. They will give you a scenario. And I heard a recent examiner who came out, he was asking, there was a question on OBG, ma'am. It was so confusing. Like they gave both forceps and vacuum, and there was a big scenario. We got confused. So don't get confused. Read the scenario, look at the things, and then choose wisely. Okay?
Ma'am, they can ask anything.
I don't know, but this one, I was like, one thing, Munjal sir's PPT repeat questions has this one. And second thing, one exam fellow who, after exam, he told me, ma'am, specifically they asked me whether it's a forceps or whether it's a vacuum. So it's important to know these things. These are the basic things. You should know this. And see, why I am embarking on OBG so much is like, see, OBG is the easiest one. You can score well. Even if your score has been reduced in some other part, I think so. They look only into the overall score as 60.
Ma'am, the paper is coming portion wise or randomly one question is OBG, one question is from medicine and other is from
Random. They will not, you will not even know how many OBG questions came, how many GYNEC questions came. It will be like one after the other. It is like, and one thing I was telling you from my every class, it won't be so simple questions here because we are lazy in making big questions. It will be scenario. They'll give you a scenario. A patient who is 37 years, who is known to have DCDA twins, last scan. So they'll give detailed explanation of the patient. So if you are very slow reader, you can't even complete all the questions in one go. It is very tough because for us, we are teaching you only the concepts. That's why our questions are simple and crispy. Exam, don't expect this. There will be big scenarios. Like you can like see that some master the board questions I just saw yesterday. So like that, you will be giving case scenarios.
Okay, ma'am.
So
I think it's enough for today.
Yeah, this is the last question. I am also done.
We are hungry now.
Yeah, I know because it's already late. Okay, so just go through the questions. I think next mock what we will see. I don't know who is going to tell. If I get an opportunity, I think I have 10 or more questions. We'll see further next time. Okay.
Okay, ma'am. Thank you very much.
okay.
All the best for everyone. Prepare well, dear. Bye.
Bye. Thank you very much.
Thank you. Thank you, ma'am.
Bye.
Thank you, ma'am.
Bye, dear.